Hello, everyone, and a very, very good day, everyone. And today we have yet another interesting chief guest with us. And this is podcast number 11, where we are talking about kidney health and we are talking about dialysis to transplant journey. And this is very important topic, and it will be very, very helpful for everyone. That's the reason we have invited Dr. Guhan, and who is master and specialized in the same field. And doctor will walk us through on various aspects how we can improve overall the kidney health and how we can improve the overall well-being also as well. And uh, and what I will do, I will share my screen just to give the quick intro of a doctor. And this is the topic we are going to discuss today. The topic is that the dialysis to transplant, and this is none other than Dr. Guhan. Doctor, I'm taking so privilege and honor to welcome him for our uh, YouTube channel as a chief guest for him. And then just to briefly discuss about his education front and then professional career, he's done the MBBS and then MD in general medicine and nephrology, and he has been associate as a assistant professor, National Center for Aging, and then he has been treating various patients at consultant nephrologist at CURI 1. I'll keep that address also as well, just in case if you wanted to meet him, you can meet him also as well. And mentorship and learning, he has been taking so much privilege and associated with the Dr. Muthu Jayaram. Muthu Jayaram has been there with us for almost 3 times, was given the name and the coin Dr. Guhan to be invited. And I said, it's a fantastic idea. Why not? And now we have Dr. Guhan also with us. So and I really like the quote which he has: every patient is a teacher, continuous learning every day. And while I'm taking absolute privilege and thanks to Muthu Jaraman also as well for tossing up his name. And I'm also very happy to promote whatever the initiatives we can bring to have the good healthy everything, right? With that, and once again, a great, great, great privilege to welcome Doctor. How are you, Doctor, today?
Hello, sir. I'm doing good. Thank you. Thank you so much for that very kind introduction. It's been an honor to be here, and very excited to hear about this when Muthu ma'am told me about this idea. I mean, it's an excellent initiative by you. I mean, to want to use this as a completely a health awareness initiative. Not many people come forward to do this, and just your idea was very inspiring to me and was very interesting. And as you mentioned, I mean, Muthu ma'am has been more than a mentor and guide to me at CURI. And the little time that I've known her, I've always been inspired by all the way she conducts herself, to the way she sees her patients. And she has ma'am has a lot of long term follow up patients. Around 30 years, the ma'am would have followed up patients, and families of patients, and the way she has a rapport and the way they believe everything that ma'am says and truly trust that doctor. That is, I feel, something that we are lacking these days. But somebody who truly trusts the doctor and truly believes that the doctor does something for their good, all those things. I mean, there are a lot of things that are always inspiring. And when ma'am told me about this opportunity, I just thought it's a wonderful idea, and really, really happy to be here. And thank you so much for the opportunity, sir. I just want to, hope that this is really educating a lot of people. And the main purpose of this is to try and, break that barrier between a doctor and a patient, and to try and very smoothly make sure that even a patient understands what nephrology means and what kidney health means and what dialysis and transplant means, which is the main theme around which I felt today's discussion should be.
Okay, wonderful, wonderful, doctor. So let's start with the ice breaking, and then, yeah, of course, you have a wonderful deck, and I cannot wait to see that deck also as well. So what inspired you to become a nephrologist, doctor? So, why nephrology? Why not the other domain? With that, we can go ahead and share your screen, and then keep going, doctor.
So somehow in when I was doing my MBBS from Tanjore, somehow surgery was something interesting to look at, but I felt I was not somebody who was very very good at my hand skills. So I decided never surgery would not be my cup of tea. So I said, okay, we would do medicine. That's how the journey to MD General Medicine started, and it's very fascinating how each disease, never reads the textbook. We read something on book, but when it comes to a patient, it's a completely different condition that we're treating. And to see a patient as somebody who's undergoing a difficulty, and us trying to make that person's life 1% better, there's nothing more satisfying and gratifying than that. And when I finished MD, somehow I didn't want to do specialization. I wanted to stay in MD. So then I said, okay, let us choose a subject that is as close to medicine as possible, and plus inspired by mentors at the others. It was always inspiring to see such people. And I felt it was more of distilled medicine and refined medicine. You have to note every small lab value. You have to note every ml of fluid given, every ml of urine produced. It's more of a very refined medicine and a very purified form of medicine, which every drug, every dosage, every mg matters. And that's why I think it inspired me. And each day becomes a journey. And as I said, each patient teaches you so much about the science of nephrology.
Excellent, excellent. And as you rightly said that, being doctor, you must need to have a attention to details and all that, as you very well quoted, Doctor. Yeah. Yes, Doctor. The stage is all yours, and please walk us through the detail which you have prepared in beautiful slide.
Sure, sure. Yeah.
Yeah. Yes, Doctor. We can see a screen. You can go. Yeah.
It's my scene visible,
Yes,
sir?
yes,
Yeah.
yes, 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 yes.
Yeah. So I just thought we'll walk through a few patients and a few patient stories today. And that way, maybe, it's a story that we would have all seen somewhere. And I thought this will make an understanding of the science of nephrology better, especially for a patient. So this was a 30-year-old gentleman with no known comorbidities. He was not a smoker. He does not consume alcohol. He had a history that he was born in India, somewhere near Kerala, and he'd worked in the Gulf for around 8 years. And it was pretty heat exposure, strong around 10 to 12 hours of day. And he was diagnosed with kidney disease. So they said this is risky to be here. So please go back to India. And he came with a creatinine of 1.9, and the scans showed a contracted kidney. So when the kidneys are shrunken on ultrasound, that almost says that it is a chronic kidney disease, that it has been a long drawn process and the kidney has lost function. So in this fear and anxiety, he came to the OPD, and he asked a simple question, sir, I've been told to have CKD. So what does that mean? So before we understand about chronic kidney disease, the first thing that anybody should know when you understand kidney disease is that there is a word called as creatinine. And I'm sure we've heard about this word called creatinine on multiple places, but we never realize what its actual purpose is. So to put it very simply, when your kidney function declines, your creatinine level increases. So it is a very simple logic that when the kidney function starts dropping due to multiple reasons, it can be due to age, it can be due to BP, it can be due to sugar, it can be due to painkillers, it can be due to multiple reasons. And because of this, when the kidney function drops, the only reflection is that the creatinine level goes up. And why it is important to monitor creatinine is that kidney disease, unfortunately, doesn't have symptoms. It takes about 50% of the kidney function to be lost by the time you have any symptoms. The symptoms could be facial puffiness. Symptoms which is very commonly missed but very significant is froth in the urine or bubbles in the urine. All these symptoms can happen early, but most of the time it happens at a very late stage, and by that time the damage is already caused. So which is why it is very important that we do a master health checkup when we cross the age, and we do a so this is the first important. Sir, please give me a medicine, I want to lower my creatinine level. What is important to understand is that it's not like BP or sugar. When you can give a medicine and lower your BP, you can give a medicine and you can lower your sugar. But what happens is there is no medicine to lower the creatinine because creatinine is just a marker. It gives you an idea that the kidney is not it goes out when the fire is in the building. So that is what the creatinine is. So the kidney is burning, and the fire alarm that rings is your creatinine. So if you ask me, sir, can I just switch off the alarm? So that's the kind of question. Is there a way to lower the creatinine? That's a similar analogy. So there's no point in lowering the creatinine. And if somebody is telling you I have a medicine to lower creatinine, they're obviously, exploiting you is what I would be. And we as nephrologists, if ever there was a medicine to bring down creatinine, we'll be the first people to prescribe it. So that's very important to understand, why the creatinine goes up and why it's not possible to give a single medicine and bring down the creatinine. It's more of a treatment of the cause. We try and identify why the creatinine is going up. Is it due to uncontrolled BP? Is it due to uncontrolled sugars? Is it due to long duration of BP and sugars? Is it due to an obesity? Is it due to some painkillers or drugs or native medications? Is it due to their lifestyle changes recently? All of this can end up causing kidney injury, and we try and correct that cause, and that is when the creatinine will be controlled. And this is another thing that off late is being another myth among the community. People think that there is a blood test called EGFR. So it is seen on your many of your estimated GFR, which just uses creatinine. It puts it in a formula for your age. We commonly use the CKD EPI equation, and it helps to tell you again what your kidney function is. So it is not a blood test. Please understand. Please do not, spend money doing an extra money doing your EGFR test because it is nothing but a calculation. It is not a blood test. But what this EGFR tells you is, this is your general picture to show your what the staging of kidney disease is based on your GFR. So the value that you see on your lab report, if it is more than 90, it is grade 1 and this is relatively normal. As the GFR goes down, this is when you have the possibility of a kidney function drop or a kidney failure. So to put it simply, when your EGFR is talking about end stage kidney disease. So, here again, we need to understand that there are two types of kidney injury. One is acute kidney injury, another one is chronic kidney disease. What do you mean by acute kidney injury? Is sometimes you would have probably a fever, or you would have had a urinary tract infection, or you would have had a recent painkiller intake. Any of this, you would have had normal creatinine. Your creatinine is around 0.6 to 0.7. When you have an issue like this, the creatinine goes up to 1.3 or 1.4. We correct the cause and it comes back to zero point 0.7. So this is an acute kidney injury, something that has come off late, come recently, hit the kidney, recovered, kidney is back to its normal function. The other thing that we're talking about for long-term dialysis, transplant, and all that is for chronic kidney disease. That is when step by step, with age, with multiple factors, the kidney drops its function, and then it's more of like how you have joints degenerating, you have your vision blurring, you have your hearing sensation getting lost. Similarly, the kidney starts to slowly lose its function. That is your chronic kidney disease. So today we'll predominantly be talking about the second part, which is your chronic kidney disease. And to realize which stage of CKD the patient is, this chart helps to let them know based on the estimated GFR. So, moving on to our second patient. So, he was a 51-year-old gentleman, the classical history of 7 years of sugar, 3 years of hypertension, BMI around 29, mild leg swelling, and he was diagnosed as CKD 4 years back, and that time the creatinine was 1.9. Mostly, these patients are on periodic follow up. They are advised medicines for BP, for sugar, for their protein leak, advised lifestyle measures, and they are asked for periodic follow up. Sometimes, what happens either they miss follow up or they miss medicines or they change dosages or some point of time, these patients come back, say 7 years later. So this patient came 7 years later, and that time he had leg swelling, he had a decreased urine output, and he became breathless. And that time we saw his creatinine was 7.5. which comes to a formula. If you put it in the formula, it comes around 6 ml GFR, and the potassium levels were 6.3. So these are all emergency indications to thing that always people don't understand is hemodialysis has evolved a lot over the years. Initially, it was somewhere around 1950s and 60s, and prior to that, dialysis used to be a very horrible, very painful procedure, high degree of complications. People used to keep vomiting. We used to use acetate for dialysis. This is the dialyzer in this image. This is what is used to purify the blood. This used to be a cellophane paper, what we used to wrap our burgers and our wraps. We used to use a lot of that cellophane paper to try and filter. The tubings were absent. There were so many complications that were there. And the other problem when dialysis started out was not everybody had access to dialysis. In fact, there's very interesting history if people are interested to read. There was something called as a God committee where they put in 4 or 5 people in charge in that country, and they said they can only decide who can get dialysis. So if the God, they were nicknamed the God committee. So if they approved, you get dialysis. If you didn't get dialysis, you would die. That is how scarce our resources were, and that is how initially it was such a painful procedure. And we fast forward to 2025, 26 now, and we see that there is so much of advancement in dialysis. So it is a simple process wherein, if you can trace this out, blood comes out of the body of the patient. It goes through a dialyzer, which is where the purification happens, and the clean blood returns back to the patient with all the used fluid entering out as the exit. So here you have a dialysis fluid which is passed in through in this direction, and the blood flows through here, and by multiple mechanisms, the blood is purified. Fresh fluid free keeps coming in, fresh blood keeps coming in, pure blood returns, and the dirty water is cleared. So this is how this dialyzer is what does your kidneys function. So basically, it is a brilliant invention in that there is no other option in any other organ of the body. If your brain is not functioning, you don't have an artificial brain. If your liver is not functioning, you don't have an artificial liver. But this is a wonderful intervention of science wherein you have an artificial kidney. You have a way to clear out your waste, and it has come to the extent that people come very casually to dialysis centers, do their dialysis, and go about their routine lives. And there is the other misconception about dialysis is that it is painful. Only this part when you insert the needle is painful. Apart from that, that 4 hours of dialysis that they do, patient has no pain whatsoever. In fact, if you visit our dialysis unit, you will see patients watching movies, you will see patients listening to devotional songs, you will see patients, gossiping about each other's family issues. You will have patients who are reading storybooks. You will have a completely it's you would think I'm saying this without saying, but it's a very fun 4 hours for them, and they lie down, they discuss all this, and then they go back home. So it started off as such a scary, such a uncomfortable way of treatment, but today it has come to the extent as such a comfortable way of living. So basically, to give you an idea, patients just come for 4 hours, either 2 days or 3 days a week, and the 12 hours alone, they're in the hospital. They do the work. So this filter does the work that the kidney does. It's like almost like, you have a dustbin at home. 3 days, all the waste accumulate. And once in 3 days, you clear it and put it in the main bin. Right? So it's just replacing the kidneys function. It doesn't treat the kidneys. It doesn't solve your problem, but it helps to clear the blood of the waste that have accumulated. This is how dialysis actually helps the patient. And before even one session of dialysis, 2 sessions of dialysis, patient crossing that was such a difficulty. Now there are, patients who are on dialysis for 15 years, for 20 years, and they are doing well. So, and again, accessibility, as I said, we're talking about God committee. Now we have dialysis centers at almost every nook and corner of the city and the state, where we have all GH, all government headquarters hospital equipped with dialysis services. So the reach of services is also has improved tremendously. And is this always a very smooth process? What is the major hurdle that we identify? I think the problem that we as nephrologists find out is that the finding a good access. So you need a way to get the blood out of the patient. And for that, there are multiple options. So the first option here is your catheter, which is a plastic tube which is inserted, which is used for any emergency dialysis initiations. Or you can have like an AV graft, arteriovenous graft, or you can have an AV fistula. So these are your three options. And somehow getting this is very difficult for every patient. This if this fails, everything fails. So this is why we call it the Achilles heel of our hemodialysis. So if you want to ask me, sir, which is the best option to do dialysis, it is always your AV fistula. So this is your best option because you're not using any plastic. There is no outer plastic tube which can get infected, which can get contaminated. So basically, two parts of the artery and the vein are tied up together, and this way you put a needle and you do a dialysis. The only thing is this requires your time to use. So this time to use is slow. If you do a fistula today for a patient, it takes around 6 weeks for that fistula to mature. And it's not a fixed number. Sometimes we see it maturing in 4 weeks, sometimes it takes around 8 weeks. So if you want somebody to do emergency dialysis, this is not an option. This is where it becomes a major issue because our patients are mostly anxious. I mean, it's understandable. It's a new form of therapy according to them. So they're like, sir, I don't want to do dialysis. Give me anything else, I will do, but I don't want to do dialysis. So they think of it as a life sentence for them, but it's actually a way to liberate yourself and to get back to normal life. I mean, and again, that is another major misconception that I've seen a lot of our patients, go through. They think that if you're going to dialyze, you're going to be sitting at home and doing nothing else. Absolutely not. There are patients who are working in the police, working in the armed forces. There are people who are working as librarians, teachers, AC mechanics, auto drivers from all cadres who come here, do their dialysis, and the remaining hours of the week they work. They're in fact the breadwinners of the family. They change their slots accordingly. They will tell me, sir, I'm working in a school, so I will come for dialysis at 4 o'clock in the afternoon. So they fine tune it to the extent of it not even affecting their routine schedule. That is how it is. It has become like a customized treatment. And to be very honest, many of our patients know more than us on dialysis because they become so comfortable with the process, and they know the mechanics, and they know what happens. They know when their fistula is good. They know when their fistula is not having good flow. When the alarms, they teach us on what happens. That is how much dialysis, almost runs on its own on many of its times. So AV fistula is what I would say is the best access if it is feasible. AV graft is another alternative. But when you have somebody like our first patient who had to come with an emergency indication for dialysis, we end up putting a catheter like this. And the advantage is the immediate use. So you can immediately use that catheter. So fistula is the best, graft is a good alternative, but catheter is the last resort. So what we generally do is we put a catheter, we do dialysis at that period of time, we immediately create a fistula. For 6 weeks, we manage with this, and then after a period of time, we switch them to the AV fistula. So this is not the only method available for dialysis. There is another method called as peritoneal dialysis. So this is something that has improved a lot of rate. Again, accessibility has improved a lot. We didn't have connection, we didn't have contacts, or we didn't have logistics to bring this equipment into our country until a very long time. But now we have something called as continuous ambulatory peritoneal dialysis. So this is a way in which you can do dialysis with a tube inserted in your stomach. So this is peritoneum, means a lining cavity in the abdomen. We do a small surgery, put in a catheter into the peritoneum, and the patient and the caregiver can do dialysis at home. So what they do, it is just like when you wake up in the morning and you drink a glass of water. They wake up in the morning and put one bag inside their stomach through this tube. They close the tube, they wear their dress, they go to their work, and then during lunchtime again, they connect that catheter, drain the fluid, and then they put the next bag, continue their work in the afternoon. Night they come back, drain the bag, put another bag, and they go to sleep, and this goes on again and again. The only initial surgery is for this catheter to be placed, and after that, dialysis can be continued at home. So, why has this gained a lot of interest of late is that your activities are not impeded. For hemodialysis, if you really think about it, you need to come to the hospital either 2 times or 3 times a week. You come there, you wait, you need a caretaker, so a husband or a wife or a mother or a father is there. So there is a lot of caregiver fatigue, there's a lot of caregiver burden, and then there is out of pocket expenses of travel back and forth. So all of this is probably the slight issue with hemodialysis. And to avoid this, you can do it at home. It is a way to do it at home. It's a it's a mode of home dialysis in a way. And the other advantage is it is done daily. So why is it an advantage? Is it more, you would ask me, isn't it more of burden to do it daily? It's because it's done daily, it's almost like your normal kidney is functioning. There is no accumulation of waste products. Sometimes what happens in hemodialysis, we suppose we give them a slot and say, so Tuesday and Friday, you come and do dialysis at a 2 o'clock session. By Monday, sometimes they become very breathless or they have high symptoms. So because it's like your waste is accumulated to a high point. It's like you've not cleared a dustbin for 4 days, 5 days in a row. Because of that, the patient becomes symptomatic and they have to be restricted on how much food they can take or how much water they can take. But when you do it on a daily basis, this replaces and does it like almost like a normal kidney function. So they can eat what they want, they can drink what they want on a day to day basis. The only caution is that it requires an assistance from a caregiver. Doing it individually is slightly difficult. And because you're handling this catheter and you're not a medical personnel, you should make sure that you maintain your sterile precautions, washing hands prior to procedure. And we have like a training module for the patient and the attender, and we tell them how you can do it sterile. And it's not like you need to be educated. So we have seen people who have studied only up to third standard, but they would know CAPD perfectly and even better than a doctor or a healthcare worker does. It's more of just repetition of a period of steps, but then it requires care because when you do hemodialysis, every the onus is on the hospital and the technicians. Whereas when CAPD is done, the onus comes back to the patient. So this is the major difference between the two. But the other thing is that this is something that is a major issue of late for us. So to give you context, when we do hemodialysis, the major barrier from the patient side is the access. The major barrier from the hospital side is to get in a lot of water. So I don't know how many of the people listening to this will know this, but to do dialysis for one patient for one session, we need around 120 liters of pure water. So for one patient for one session, we need around 120 liters of pure water. And this is pure water. Imagine the reject water, imagine the raw water that enters. So over a period of time, what we are really worried as even in the nephrology community is how long will we be able to sustain this? What can we do as a community to decrease our water use, and what are the ways that we can help save the planet when we continue to provide care? On the one hand, you can't deprive people who have a difficult disease and you want to help them get better and heal them in some way. On the other hand, you don't want to destroy the planet. Although CAPD, there is not much, not as significant water. Again, there you're using dialysate fluid. Again, so they're using 3 bags per day or 4 bags per day. In month, one patient has around 120 bags. So there's a lot of plastic waste that is generated. So there are a lot of issues in both forms of dialysis. And although we do adopt a lot of green nephrology practices, is in, we have dialyzer reuse. We sometimes the plastic waste, we try to reuse the dialyzer adopting the required safety precautions. And then we try to, all the discarded water, we try and use it for either toilet purposes or for our watering of the lawns or watering of the plants. So, we make sure that the reject water, although it is rejected for dialysis, it is still a very pure form of water. So we use it for other practices and other ways in which that water can also be helped. So we are doing our bit, but this is something that continues to bother us. And which is why even this year's World Kidney Day initiative was about how we can help the people at the same time protect the planet as well. So this is something that we as a community are still finding out solutions to this problem.
One
So
one
coming back,
question,
yeah,
doctor. Yeah, one
yeah,
question, doctor.
sure.
Can we switch from the hemodialysis to peritoneal or peritoneal to hemodialysis? Can you
Yes,
please
yes,
put
sir.
some light on it?
Yeah, yeah, very nice question. Thanks. So what we generally do is before we start CAPD, sometimes the patient's creatinine and urea levels will be very high. So for the initial surgery, as I said, to put in this catheter itself, they may not be fit for the surgery. So what we do is we give a few sessions, 2 to 3 sessions of hemodialysis, and then we go ahead with this process of catheter insertion. And this catheter insertion also as like a fistula maturation, it requires around 2 weeks for it to get firmly positioned in this place. Sometimes the catheter can move, can migrate, this tip can go somewhere else, or this can move, change its position. So if there are all of these complications, they will have to continue hemodialysis until this CAPD works perfectly. And as I also said, there is a risk of peritonitis, which means like there is some infection or inflammation in the abdomen. So sometimes when this catheter becomes infected due to many reasons, it can be due to some, maybe sometimes having some pets at home, sometimes handling of the catheter. What happens is, for whatever, most of the times what happens, until 1 year or 6 months, the patient follows all advice strictly. But then at 6 months or 1 year, some kind of lethargy creeps in. They kind of skip one step of the process. They don't clean their hands, and immediately this kind of picks up an infection in the peritoneum. If that is the case, the initial treatment, we give antibiotics, we see if it works. But sometimes if it doesn't work, we end up removing the catheter and we give rest to the peritoneum for either 4 weeks or 6 weeks based on what infection happens. And then again, we put the patient back on dialysis, hemodialysis. If again hemodialysis they do have complications, we again switch them back to CAPD. So it's like an option can be, both can be switched over at any period of time, but mostly at the start when we offer the patient with options, we tell them you can take a call on which you would be comfortable with. Sometimes you don't have a caregiver at home, you won't have somebody to connect, disconnect, and it'd be difficult for you. And for some people, for somebody to come to the dialysis center and go will be difficult. They may have vision issues, they may have mobility issues, they want to take care only at home. So we offer both to the patient. We ask them to take a call on what is preferred. The initial choice is left to the patient, and it's like a shared decision making. But at any point we do switch over from both hemodialysis to peritoneal dialysis and peritoneal dialysis to hemodialysis.
Wonderful, doctor. So, does the dialysis itself heal the kidney or damage the kidney, doctor?
No, sir. No. So again, it doesn't do both. This is another thing that many people ask. So, sir, I want to do dialysis, but within 2 months, can I get back to my normal life? It is never the same. So, as I said initially, if it is due to an acute kidney injury, if there is something that is suddenly affected the kidney, I have a case at the end. I'll probably add on to this at the end. That can recover your kidney function and get back. And even then, the kidney just supports the dialysis just supports the kidney function, and the kidney heals on its own. It doesn't help in healing. At the same time, it doesn't cause harm as well. The kidney has to heal on its own, and the dialysis just supports the kidney when it's not. It's like a substitute when somebody is not doing well. That is how dialysis works.
Very good response, doctor. Yeah. Please go on, doctor. Thank you so
Yeah,
much.
sure.
Yeah,
Yeah.
very well